proportions of patients alive without progression, for example, at 2 years. So the numbers that I have in my head when I'm thinking about patients in the clinic counseling, when PD-L1 TPS is less than 1%, with our current treatment options, it's generally maybe a 5 to 10% chance of 2 years of disease control. When patients' PD-L1 gets above 50%, those odds increase to 20 to 25% odds of 2 years or more of durable disease control. So the odds definitely shift, and that pairs with the odds of response. So I would definitely say response has predictive value for overall survival, though imperfect.
That's helpful. And I'll continue with lung cancer, Dr. Eames. More FT-related questions now. We have seen first-line, second-line data in non-small cell lung cancer. What did you find more exciting as a treating physician? What parts of the data was most appealing for you? Where did you think FT could serve? What patient population FT could serve the most?
Yeah, I think the big question and comparator, and definitely this would be between trials and between clinical experience with CTLA-4 agents and FD is what comes to mind. So we have pembrolizumab as the backbone as most of our treatment in first-line non-small cell lung cancer. There are other PD-1 or PD-L1 inhibitors approved, nivolumab, cemiplimab, durvalumab, but pembrolizumab was the first approved in the space. So I think as far as typical use, that's very broad. So you can think, one way to think of the available regimens in the FD data is, so FD is combined with pembro, which we have as the backbone. So how do we compare and contrast with our other regimens available? The only other dual immune therapy without chemo regimen approved uses ipilimumab, an anti-CTLA-4 antibody. So that's one of the contexts that I think about the FD data that we have here. Again, though this is single arm data, and so intriguing, but further study is warranted. So when I think about comparing FD with a CTLA-4 antibody, the biggest thing that jumps out is these do appear to be lower toxicities than we see with the CTLA-4 antibodies. I think time will tell on the durability of clinical benefit. That's an unanswered question in the field. But then you could say, okay, well, if we're comparing the CTLA-4 antibody with FD as far as treatment landscape, where does that currently fit in the treatment paradigm? Could something like FD and pembro supplant usage of that? And usage of that regimen to me is by and large in patients who want to avoid chemotherapy, more for personal reasons that they have an aversion to chemotherapy coming into the conversation, and I'm able to accommodate that. But not as much patients with the medical illnesses that would prevent full dose chemotherapy. But the reason it doesn't currently include that patient population is because of the doubling of toxicity, basically, that we see with CTLA-4 antibodies added to our PD-1 or PD-L1 antibodies. So this could change the calculation a bit if in more mature data, bigger data sets as well, we do see that real reduced toxicity of FD compared to a CTLA-4 antibody. You could potentially even broaden the envelope on the population currently getting that double immune therapy regimen. So that's, to me, the biggest area of intrigue and potential inroad for this application.
And it sounds like you won't necessarily compare it to the chemo-pembro combination. You would compare it to IO-IO combination patient population.
So I think the chemo-pembro comparison is interesting. I think we all have a degree of comfort with chemo, not enthused about it by any means, but have a good understanding of the expectations with chemo and the possibility of shrinkage when we need more rapid shrinkage and what that entails. So there could be mechanisms to compare and try to introduce it into that conversation. And especially in the PD-L1 less than 50% cohort, I think it's interesting to see as I'm talking through, the thought process around it. The other key factor to me is just needing to see a little more mature survival results and ideally some more patients as well before I'll feel comfortable making that leap to the chemo plus immunotherapy comparison. questions. But I do think it's definitely important to think about, and we'll keep doing so.
And we received some questions from the audience. I'll ask that, and it's lung cancer related. You're not taking any breaks yet, Dr. Yunusbin.
No problem.
For first-line non-small cell lung cancer, duration of response data was available at SITC last November. If overall survival data is still not available, doesn't it mean the median overall survival has to be at least duration of response plus 6 months, which would account for 27.5 months or even longer?
That I'm not as sure of the numbers, but I do know that the intention is to present when available at an upcoming meeting for the survival.
So, just to add to that, Ahu, that's the thing about clinical trials is the data obviously are maturing real time, but they're not analyzed real time. So, as Dr. Abrams rightly alluded to, there's intervals the data are looked at and updated, you often associated with a reasonable amount of time between them. So it doesn't necessarily mean that the fact that we haven't got it now doesn't mean to say that means it hasn't changed. It just means it may not have been reanalyzed with clean data, because all the data when it comes from sites has to be reviewed, monitored and cleaned to make sure that it's accurate. So that's not kind of completely real time.
Certainly makes sense. And Dr. Forster, I'll continue with head and neck cancer. What we have seen is second-line head and neck cancer data. How do you expect, I know this is not it's a predictive question. How would you expect that to translate in the first line? That's number one part of the question. And then number two is, what did you find most exciting from the data you have seen in the second line? What was most appealing for you?
So I think that it's interesting. So in different settings, the activity of these checkpoint inhibitors may vary a little bit on line of treatment. There's certainly rationale for why you might think that different drugs, whether it's chemotherapy, radiotherapy, other treatments, may change the immune landscape and change the sensitivity to these drugs. Interestingly, in head and neck cancer, whilst those theoretical sort of considerations are certainly there, we saw the response rate consistently now with both pembrolizumab and with nivolumab in a number of different early phase 1 and right through to pivotal phase 3 studies, consistently showing a response rate in the all-comer population with nivolumab and with pembrolizumab of around about sort of ranging from 13 to 18%. So that we've seen that sort of number consistently in second line, and actually very similar in the first line. So from a response rate point of view, it looks like the response is fairly similar whether it's given first or second line. So I think that obviously the real patient need is in the first line setting now. So when TACTI-002 was first sort of designed, at that stage, the immunotherapy was being used as a second line option, whether it was Nivo or Pembro. But obviously the landscape's changed now, and now it's a first line setting. So there's absolutely no value in looking at Pembro plus as a sort of pivotal treatment in the second line setting. In IO naive patients, we're not focusing today on the population of patients who've been previously treated with Pembro and developed resistance. That's a different space altogether. But if you're looking at PD-1 naive patients, there's no value in doing that in the second line anymore, because those patients really are treated in the first line setting. So I think that there's no question that where the need is in the first line in this recurrent metastatic setting. And I feel quite comfortable with the idea of translating at least, we would expect at least as good activity in the first line as in the second line. And we've seen that with the Pembro alone. So the fact that we've seen response rates in the all-comer population of around 30% and in the PD-L1 positive population of over 50% in the second line setting, I think we'd expect it to be at least as good as that in the first line setting. So I think that that's really very promising. With minimal additional toxicity, we're roughly doubling the likelihood of gaining that response. And as Dr. Abrams and myself have been saying, that response, once you gain it, has got a good chance of being durable. So So actually, I think that I think it's really exciting to see that data in that second line setting, and I think there's every reason to expect to see similar activity in the first line setting. And of course, the questions being asked in TACTI-002 is honing in a little bit more around those PD-L1 CPS positive negative questions about the added value of the combination to try and get a little bit of randomized data for the PD-L1 positive population, and confirming activity with a few more numbers in the PD-L1 negative population to try and to guide, because one of the things we haven't really touched upon, which is not necessarily specifically relating to license, but it's relating to trials, and it's actually quite difficult to design trials in a landscape that's very busy, and we haven't really talked about it, but there's lots of trials going on, even more in lung cancer, but lots in head and neck as well, looking at some of those other loads of different things, hundreds of trials, in fact. So you have to have a pretty good idea about future-proofing your study, as well as thinking about an opportunity to recruit into the study, and that there's going to be equipoise by the investigators, and importantly these days with our patients, that they're willing to embark on the trial in that setting. So I think these data are really, really promising in head and neck. I think that the response rates are really very good. But I do think that we need slightly more data to persuade ourselves, to give ourselves confidence that this is something that we're going to want to take into that first line setting, where with the other opportunities available there, both in trials as well as the standard of care.
And follow-up question, again on the head and neck side, Dr. Forster. Given that we will have the TACTI-003 readouts this year, what, as an expert in the field, what would you find very exciting as a very good data? If you could give us some numbers, if possible, based on your expertise, like what ORR, what duration of response would be a solid data according to your view?
Yeah, so I mean, I think that if we see, a similar response rate to that was seen in TACTI-002, that I wouldn't really expect or be hanging on a higher response rate than that. I think that would be adequate for me to continue my enthusiasm with this combination. Of course, when you start thinking about the go no go decision about going to a phase 3, large multinational study, I think that is, you need a little bit more, as Dr. Iams was sort of talking about earlier. You need to have a bit more confidence in the durability of that response and in the some of those time to event outcomes. It's another question that was discussed endlessly amongst clinicians and other groups around how big a difference you need to see. I think that in this sort of context, I think that an improvement in survival outcome by 2 or 3 months would be very meaningful. And given the fact that the combination appears to be really have very minimal additional toxicity other than those local reactions to immunotherapy alone, to pembro alone, I think that's I think that sort of level of response would be clinically meaningful as well, of sort of outcome change.
Very helpful. Another question we receive is one of our audience is asking, what are the numbers for chemotherapy versus radiotherapy or surgical intervention for head and neck cancer as well as non-small lung cancer?
Shall I start?
Sure, please.
So they're very different in the two tumor types. I look after patients with head and neck cancer as well, but I won't refocus on that today. But they're very different. So in head and neck cancer, around about 80% of patients, or at least 80% of patients, will present with locoregional disease at their first diagnosis. So the vast majority of patients will have disease that's in the head and neck region and not metastasized. And therefore, most of those patients, if they're fit enough, will have some form of locoregional treatment. And that, if the disease is very, about half of those patients will have locally advanced disease. So they'll have disease that's stage 3 or 4, which essentially means that they've got poorer outcome with about a 50% chance of the cancer coming back, even with very aggressive first line treatment. So, but those patients with locally advanced disease, the majority of those, what type of local treatment you use depends a bit on the location. So oral cavity cancers tend to be treated with primary surgery, with or without post-operative radiotherapy, whereas there's been data showing that you can have a chance of saving the larynx and sort of organ preservation if you give your if you treat with chemoradiotherapy, you may avoid the need for a laryngectomy, which has got quite a patient sort of impact. So the type of local treatment is quite variable depending on the site, which we can go into more detail if that's of relevance. But I think the probably more important is around about 80% of patients will present with, or 85% of patients will present with local regional disease. That will be managed with some sort of package of local treatment, chemo plus or minus. And in fact, when you asked about immunotherapy, of course, one of the big questions is how can immunotherapy be used in that first line setting? And at the moment in head and neck cancer, that's an unanswered question because so far the data have been negative in the studies looking at these checkpoints in that setting. So exactly how immunotherapy should be used with or without the FD is a question remaining to be asked. But at the moment, those patients are all treated with localized treatment with or without chemotherapy. And then it's only on relapse, which will be about half of those patients with locally advanced disease, where we start talking about these systemic treatments. And in those situations, in theory, you can do salvage surgery or reirradiation, but though the proportion of people who are able to do that is really quite small. So generally, you start talking about systemic treatment in that setting.
Well, Dr. Eames?
Yeah, so different in non-small cell lung cancer, where most patients have either stage 3 or stage 4 at diagnosis. And what that means as far as treatment is for patients with stage 4 disease, generally radiation and surgery are not used except in very unique circumstances. But most patients with stage 4 are only getting some form of systemic therapy, so chemotherapy, immune therapy, or a targeted therapy. And then patients with stage 3 non-small cell lung cancer are initially typically treated with a combination of chemotherapy and radiation, followed by immune therapy, but a majority of those patients recur and will develop metastatic disease. So in patients with non-small cell lung cancer, it's unusual for surgery to be an initial option. It's probably, again, depends on the region of practice, but 20 to 30% of patients with a diagnosis of non-small cell lung cancer will have potential surgery as an option. And then another probably 30% or so of patients, or 20 to 30, I would say, have a combination of chemotherapy and radiation as their initial treatment. And then the rest of patients generally have stage 4 disease, so at the time of diagnosis. So it's a very big group of patients with non-small cell lung cancer who are not eligible for surgery, and many are also not eligible for radiation at the time of initial diagnosis.
My last question would be for both our KOLs is, what are you most excited about for the next couple years, and how do you think head and neck cancer and non-cell small lung cancer landscapes would evolve in the next 5 years? Dr. Forster, would you like to take it first?
So there's lots going on. It's a very exciting area in cancer in general at the moment. Particularly with this better understanding of immune regulation, it's opened up all sorts of options. I mean, clearly immunotherapy, and if you extend that to think about cell therapy, cell-based therapies as well, that space is really active at the moment in context of research. I think that those cell-based therapies probably are beyond 5 years before we're getting meaningful outcomes, although there've been some interesting data presented just a few weeks ago in melanoma with some TIL therapies, which are showing some benefit. So I think that that's an area which is not really touching on head and neck at the moment, but I think will be explored at least in clinical trials. I think in my mind, one of the disappointing things in both head and neck and lung cancer has been beyond the PD-1 with or without chemotherapy. Arguably, the CTLA-4 has a small added benefit, but really there's been lots of other combination immunotherapy studies done in an unselected ways, which really haven't added as much benefit as we thought. There was lots of excitement about TIGIT recently, until recently, and other immune checkpoint inhibitors, which really haven't sort of quite delivered what we want. And that's in head and neck. The data and the trials tend to be a little bit lagging behind in the non-small cell lung cancer, but the trends are kind of similar. So I'm kind of hoping that new drugs, activating immune therapy drugs such as FD or other sort of drugs that modulate the tumor microenvironment will have more benefit than we've seen with the double immune checkpoint inhibition. And what, as a sort of translational oncologist, what I really would like to do, which is a bit of a big ask, is for us to try and select patients a bit more effectively. So it's really about understanding the biology and the biomarkers, because I think we have lots of combinations there, and it wouldn't surprise me if some of the negative studies could have been positive if we knew how to select the patients better. So I think that really what we need to be striving to do is to understand the biology in parallel with this massive wave of trials. It's a very competitive landscape, so the studies are jumping, as you alluded to, from phase 1 to phase 3. They're bypassing that. They're even getting accelerated approval on very early data. And actually, I think that we need to be understanding their biology in parallel. Otherwise, I think we're going to get lots of patients contributing their time and efforts and indeed their lives towards drugs which prove to be not that helpful, unfortunately, because we haven't understood how to develop drugs properly. So that's my big ask. But I do think it will be based around these checkpoint combinations. I think at the moment, that is understanding that and delivering that is probably going to be what we see over the next few years, hopefully to be complemented then perhaps by more complex biologics and cell therapies.
Very helpful. Dr. Eames?
Yes. So definitely novel immune modulators in combination with cellular therapies is one bucket. Two unique buckets as well that I'm kind of following broadly within the field in non-small cell lung cancer. There are ongoing developments for improvement in our oncogene-directed oral therapies. So that's kind of a steady stream, not as much of a bulk as the novel immune modulators and cellular therapy field, which is just this massive investment currently, and hopefully we can have some really good results for patients from it. So we have the evolving oncogene-directed targeted therapies, and then a third bucket that is kind of this intermediate level degree of investment in non-small cell lung cancer currently is antibody drug conjugates. So instead of targeting oncogene mutations in DNA, we're looking at cell surface expression of sometimes oncogenic proteins, sometimes just unrelated expressed proteins on cell surface, and administering antibodies to target those. Those have gained a foothold in some other histologies besides non-small cell lung cancer. Bladder cancer is a big one where they have a couple approvals now, but that's another component of the field that's continuing to evolve. So in some antibody drug conjugates, how will our oncogene-directed targeted therapies continue to evolve, and what does it look like for novel immune modulators and cellular therapy are the big three ways that I think of the field evolving.
I would like to thank you for your contribution, and it was great discussions. Thank you so much. Great to hear your perspectives about the fields, Dr. Eames, Dr. Forster. Thanks for joining us, and thanks everyone. Have a great day.
Thank you.